Share and then start the sharing the screen.
Okay, how am I doing now? Can you all see the screen? Okay, great. Well, thank you very much for having me, and this has been a very exciting symposium so far. I've enjoyed all the previous speakers. What I'm going to talk to you today about is orthokeratology, contact lenses, and their relationship to myopia control. This is a topic dear to my heart, and if nothing else, the true message of this is that I hope ophthalmologists will open up their eyes, if you will, no pun intended, to what we're going to talk about today, because I really feel like orthokeratology is a very viable entity and is critical in treating children particularly, but also adults in relationship to myopia. So here are my financial disclosures. I've been on the Speaker Bureau for both Paragon Vision Sciences, which is now part of Cooper Vision, and also for Bausch & Lomb in the past. I've kind of done this in a little bit of a question answer type of talk, and the nice part is I'm going to give you the question and I'm also going to give you the answer. So the first question is there a myopia epidemic? And the answer, or the question is, there is no myopia epidemic. The answer to that is really, that's false. There really is a myopia epidemic. Dr. Holden showed us this in a publication somewhere around 2016, where he indicated that this trend of increasing myopia is rather dramatic. And we will see close to 5 billion myopes globally by the year 2050. And Penny Asbell, who was previous editor of our journal, in an editorial in 2016, noted the same kind of forecast, that there's going to be a 50% increase in myopia between the year 2000 and the year 2050. Most of us would consider this an epidemic. In the United States, here are the numbers. In 1979, when I went through my training, we always thought of myopia as being 25%. We're now talking about myopia being 50% in the United States. India, the numbers are lower, but the trend is somewhat the same. Currently, according to the All India Institute of Medical Science report in 2021, there's a 13% prevalence rate in school-age children in India. In the 1970s, this was published to be 5%. They also note that the incidence has doubled over the last 10 years. And you can see globally, in 2010, we had 2 billion myopes. In 2015, we had 50% increase, about 5 billion myopes. The next question is, I believe in the push-pull theory for corneal epithelial cell movements. I suspect most of us have no idea what the push-pull theory is, so let's talk about that. But yes, I believe this is true. I do believe in the push-pull theory. This is the current theory that most of the active orthokeratologists are going by. And it has to be combined, obviously, with a 360-degree seal of the lens. Now remember, this lens, we talk about it as being a mold. We are molding the cornea. We're changing the shape of the cornea, but we're doing it in a very defined manner. How exactly does this push-pull theory work? Well, Ortho-K uses a rigid gas-permeable corneal mold, and it harnesses hydraulic forces under that mold to reshape the cornea through overnight reducing or eliminating refractive error for a period of time. And so centrally, we've got a positive push down onto the cornea where we're flattening. And then we have to have a zone where we have this negative pull force. We call this a sagittal zone or the intermediate zone. So here we are pushing down. Usually we'll get about 4 to 8 microns of effect. And we're also in the mid-periphery have these pull forces that create the steep reverse curve. So here's the concept of the push-pull theory. Now, the secrets of the parameters of these contact lenses really are not that foreign, particularly since our previous two speakers kind of set this all up for us. We have kind of created, not exactly a reverse curve, but in essence, we've done something similar to that. The base curve gives the push, and so we can design this as a certain amount of flattening to our central keratometry reading. And then we have to give some space for this epithelial movement to go, and this is the reverse curve. We also end up here with some alignment curves in order to get this lens back onto the surface of the eye, and then a little bit of a peripheral curve so that the contact won't be quite so tight. Let's talk a little bit about the base curve. This becomes the treatment zone. And how do we calculate the base curve? It's very simple. We just take the flat K and we calculate the prescription that we want to be corrected, let's say 2 diopters. And we take, sometimes in the higher corrections, there's a little bit of a little Jensen factor that we throw in there. But that gives us the base curve of an ortho-K mold. So let's just take a typical 43 flat curve. We want to correct 2 diopters. We would be looking at a 41K base curve. What about the reverse curve? What does that do for us? Well, the reverse curve joins this flat base curve to the alignment curve, and it creates the hydraulic pull where we get a thickening of cells in this area. And this is where myopia is often controlled. The nice part about this reverse curve is that it improves our centration for the treatment, and it creates a sagittal depth. So we're able to move this curve up and down, and we can control this. The alignment curve controls where the mold lands on the eye, keeps the mold centered, controls movement, and is often based on the eccentricity values. So here is a typical diagram that I'm using from the Paragon people. It gives, and all lenses pretty much have the same kind of concept. It gives a central 6 millimeter treatment zone. It gives a 1 millimeter reverse zone, and it gives a 1 millimeter landing zone. So the total lens starts off about a 10 millimeter lens, and then probably there's a little bit to the posterior edge ellipse on the very edge here. So we use usually somewhere in the 10 to 11 millimeter diameters. You can see it on sagittal profile. This return zone right here, in the blue, this is really kind of critical, and all lenses from different companies may have different kinds of concepts mathematically, but there is some kind of return zone to these lenses. Here it is in a profile where we want to make the point that we can control this return zone. We can control the sagittal depth. We can lay it down flatter, we can raise it up higher. And it's nice to have this mathematical control when we're ordering the lens. This is nice to see this on a kind of OCT profile, anterior segment, where you can see how this lens flattens right here, pushing down, and we're anticipating a little steepening of the corneal epithelium here in the sagittal zone, return zone. And of course, fluorescein patterns are critical to use in this to see how we are doing. Oftentimes, we'll have the patient come in with the contact lens on first thing in the morning, take the lens off and see what centration we're having and what kind of bullseye effect we're having with the fluorescein. The next question is, there is a better theory of mechanism of action over hyperopic defocus. Is there a better theory? Well, I don't think so. I think we're still using hyperopic defocus as the reason why these lenses work. And this is particularly true for myopia control. So now we're going to talk a little bit and get into a little bit of myopia control. And you can't start that without some of the critical work by Dr. Earl Smith from the University of Houston, who was working with monkey models in 2009, and he described the importance of focusing an image on the mid-peripheral retina. He described the concept of positive and negative control of curvature, hyperopic versus myopic defocus. He showed, or later on, this was verified with growing chick models, and we are looking forward to new animal models to be developed. So let's go and talk a little bit about what Earl Smith told us. Here's some concepts of that bullseye pattern of orthokeratology, where we're looking at the flattening and we're looking at a little mid-peripheral thickening and increase in curvature. Now remember, the critical part about this whole thing is that we're developing two curves. One curve for the central fovea and a second curve to fall on mid-peripheral retina. That is the whole excitement of this work. And Dr. Smith said in an article in 2005 in Investigative Ophthalmology that eye growth may possibly be retarded or halted through a precise and predetermined optical system at the corneal plane that will manipulate the peripheral optics of the eye. And here's his monkey model. The monkeys were studied over roughly 150 days to 300 days, I guess, for maturity of their optics. And one of the things that Dr. Smith did was he first took a model where he wanted to know, does the fovea control the axial growth of the eye? And here he lasered the fovea so that the fovea was wiped out, and we're just kind of using mid-peripheral retina. And what he found here is that the intact fovea was not that important to reaching emmetropia, and that these monkey eyes all seem to reach the 0 emmetropia level. Now, what happened if he did the opposite? What happened if he kind of wiped out the mid-peripheral retina with laser marks and just was working on a fovea? So the fovea here is okay, but the mid-peripheral retina is wiped out. And he did that with a YAG laser. And here he found that these peripheral wipeout abrasions were all over the place, and they never went on to reach emmetropia, even after 300 days in the monkey model. So the conclusions were that peripheral form deprivation, wiping out the periphery, can produce myopia at the fovea, that the fovea was really not essential for reaching emmetization. Conclusion is the intact periphery is essential. What does this mean? It really means, again, that the data demonstrate that the fovea does not play the dominant role in refractive development, and instead, peripheral retinal images play the major role in determining overall eye growth. So what we want to do is we want to make sure that we have an image coming in focus on the mid-peripheral retina. The concept is that we can control axial length, that the eye does not have the tendency to want to grow. This was, again, mentioned in the chick model. Chicks mature very quickly within days in their optical system. And here, Dr. Liu and Walsott at UC Berkeley placed certain lenses on these chicks to mimic central and peripheral defocus. The lenses were worn for 5 to 17 days. And in these two groups of with a bifocal design, if they had central defocus versus peripheral defocus, the peripheral defocus showed the greatest difference in axial eye growth. Again, if you wipe out the periphery, the eyes tend to get longer. And then we'd like to talk a little bit for the moment about what we're doing with the correction of myopia. So typically here, we're just putting our regular kind of prescribed myopic pair of glasses on. And we're getting the image from being a myopic image onto the fovea. But what happens here in the mid-periphery? You're moving away from the curvature of the eye. You've got what we call hyperopic defocus. And this is what we need to solve. And now we're developing lenses, spectacle lenses, that will have an increasing positive power in the mid-periphery to get this image back into the eye, into and onto the surface of the mid-peripheral retina. A couple of other concepts. What about reduction of myopia progression in different treatments? If we look at right here, orthokeratology in the middle, you'll see that the meta-analyses of many, many studies showed about 45%. Dr. Cooper, who's done a lot of study in this area of axial length progression, and particularly with atrophy. But here you see that 45% in even his study have a reduction in axial length. Compare this to low-dose atropine, it's roughly about the same. If you go to higher doses of atropine, you get a little better effect. But we know as we go to higher doses of atropine, we get increasing problems with the children tolerating it. If you go down in multifocal soft lenses, you got a decreasing number until single vision glasses do nothing in terms of reduction of axial length. What about overnight ortho-K compared to atropine controlling myopia? Well, the conclusion of this particular study by Lin and cohorts in China was that ortho-K lenses is a definitely useful method for controlling myopia progression even in high myopia patients. And this certainly has been our clinical experience. What about the suppressive effect of combined atropine along with orthokeratology? Well, they tend to work well. So the combined treatment, the conclusion here, the combined treatment of ortho-K and low-dose atropine instillation to axial length elongation showed that ortho-K alone in childhood myopia could be extended by the use of atropine, that the effect would be greater if you used a combination of both, if you weren't getting total control with your ortho-K patient. Is ortho-K safe to use in children? This is certainly a big issue. I think it is. And we used Mark Bullimore's retrospective study of a large number of patients, over 1,300 patients representing 2,600 patient years of wear. There are only 2 events of microbial keratitis. This results in an estimated incidence of microbial keratitis of 7.7 per 10,000 years of wear. Compare this, if you will, to your traditional soft contact lens wear and extended wear, which is much higher. Here's another larger systemic review by you and cohorts in eye and contact lens back in 2016. Their basic points is that there is sufficient evidence to suggest that ortho-K is a safe option for myopia correction and retardation, but also critical is, and we learned this from problems in China around 2007, 2008, when lens care and good compliance were not being followed and instructed. Fortunately, the Chinese government made moves to make this compliance a strict regimen, and we're not hearing problems with this. But the safety protocol is critical with the use of these lenses. No tap water ever. Have to use a surface cleaner, rinse with a multi-purpose solution or sterile saline, and we like to use hydrogen peroxide disinfection. Obviously, you have to follow these patients closely, but once they are stable, I still watch them every 6 months, and they're instructed to return if they have any pain, light sensitivity, or redness. The next question, there is adequate evidence-based literature to prove that ortho-K slows axial length progression in children. Can we prove this? I think the answer is true. Look at these studies. We have a study of Hirioka, which is a 5-year study, and then we have multiple other 2-year studies that have gone on both in Spain and Japan and China and the United States, all of which show that we can get effect with ortho-K and myopia control and axial length. But I'd like to show this one real briefly. This is a 10-year study. This is a long-term study in Japan by Hirioka's group. And what they show basically is, and this is refractive correction, that every year there was a definite increase when you went with soft contact lenses in terms of axial length. And it was a statistically increased amount every year for the first 6 years. But in ortho-K, there was no statistically significant increase in axial length over any of the 10 years. So I think if you're looking for long-term studies, the Japanese are giving this to us, and they have tremendous follow-up. The next question, it really does not matter what lens design you pick. I think the answer to that is false. We have 17 different FDA companies that have different lenses. And the concept here is all of these are good. all of these are useful. Some are touted to be better for higher myopia than others. Some have astigmatism control built into it. But we have many, many different systems. If you're not successful for one system, we hope that you'll be knowledgeable enough to work with a second system. The wearing of ortho-K lenses positively affects the quality of life and behaviors in children. Does this really happen? Well, I think there have been some nice studies to show that this is true, that the investigation of the effects of ortho-K lenses on the quality of life in children was looked at by Zhao and published in Eye and Contact Lens in 2018, where 100 children were studied over 3-month periods in China. There was significant increased scores in self-confidence, willingness to try new things, more active in sports and entertainment, and increased total time spent outdoors when children were using ortho-K lenses for overnight wear and instructed to get out and play. Here are the reasons given by kids for choosing ortho-K lenses: convenience in sports, classmates' recommendations, appearance, and other variety of reasons. They were very favorable in this blue zone, a large number acceptable to the patient, to the kids' attitudes to the lenses. And we did have about a 25% incidence where the kids either were unaccepted or strong resistance to wearing them. So in summary, I would like just to have you open up your eyes, if you will, to this modality. This is not new anymore. This is being used throughout the world. There are millions of kids now and adults in ortho-K lenses successfully. I personally, since 2002, with good, strong follow-up in my practice, have had no cases of microbial keratitis. And I believe that it's time for us to start to look at the literature and recommend this modality to our children. Thank you very much.